Hi, I'm Ryan Weiss, a PGY3 internal medicine resident at Lake Cumberland Regional Hospital, and this is my presentation titled Under Pressure. The learning objectives for this presentation are to review a case of cardiac tamponade, discuss the diagnosis, and understand the current evidence-based treatment regimens for cardiac tamponade. Cardiac tamponade can present rapidly or in a subacute fashion due to malignancy, uremia, or idiopathic pericarditis. Subacute cardiac tamponade may be asymptomatic early in the course and eventually lead to dyspnea, peripheral edema, and weakness. We present a case of cardiac tamponade secondary to non-small cell lung cancer. A 63-year-old female with long-standing tobacco abuse presented to the ED with complaints of shortness of breath and cough. 10 days prior to admission, the patient and her husband became ill with nausea, chills, and cold sweats. Her husband quickly improved, though she remained ill. 3 days prior to the visit to the ED, she went to an urgent care for vomiting, shortness of breath, and weakness. She was diagnosed with an upper respiratory infection and given a prescription for amoxicillin clavulanic acid. Shortness of breath and weakness continued to worsen, and thus she decided to come to the ED. On physical exam, the patient had muffled heart sounds, JVD up to the angle of the mandible, diminished breath sounds in the right upper lobe and left lower lobe, and pulsus paradoxus. EKG showed electrical alterans and AFib with RVR. The CT chest showed a large right upper lobe mass with invasion into the mediastinum. It also showed a marked pericardial effusion. The echo confirmed the large pericardial effusion with mild RV collapse. Cardiology was then consulted and for the effusion with suspected tamponade physiology and recommended a pericardial window. At this point, the patient requested a transfer to UK and was thus transferred to the University of Kentucky. At UK, the patient was admitted to the cardiothoracic surgery ICU. Given the risk for severe hypotension with the induction of anesthesia, the patient was taken to the cath lab for pericardiocentesis and a pericardial drain with removal of 1 liter of serosanguinous fluid. Pericardial fluid cytology was positive for adenocarcinoma consistent with lung cancer. Patient needed a more permanent drain per oncology and radiation oncology, and therefore underwent a right VATS with a pericardial window with a PLUR-X catheter placement. After discharge, the CT-guided biopsy of the right upper lobe mass was positive for non-small cell lung cancer. The patient was started on pembrolizumab with radiation to begin within 3 weeks with palliative intent. Cardiac tamponade can be suspected based on patient history, physical examination, EKG, chest X-ray, and echo. However, the diagnosis of cardiac tamponade can best be confirmed by the hemodynamic and clinical response to pericardial fluid drainage. From literature review, we can extrapolate the treatment below. Hemodynamic unstable patients can be stabilized with IV fluids. Pericardiocentesis can drain the fluid rapidly, and a pericardial window can provide a more permanent drain to continue to treat the pericardial effusion. If the patient is hemodynamically stable, the patient can be watched with repeated physical exams and echoes. In inflammatory effusions secondary to pericarditis or connective tissue disease, the patient may be treated with anti-inflammatories such as NSAIDs or colchicine. This case demonstrates the classical physical examination findings and imaging response to therapy for cardiac tamponade, as well as underscores the importance of early recognition.